In this edition of BRG's Nurse Executive Podcast, I speak with Josephine Wahl, a registered nurse by background with 10 years experience as a chief nursing officer in a large metropolitan area. Jo is currently an associate director in BRG's Care Transitions team. We discuss nursing leadership's role in care transitions. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Jo, thank you so much for joining me today.
Thank you for inviting me to talk about this very important topic.
Yeah, so let's talk about care transitions. It's essentially case management and throughput, right?
It is, but it also has really become more complex than that. Case management is discharge planning, utilization management, those components of care transitions from an acute setting to a post-acute setting. But care transitions is also in the post-acute world. COVID has changed and highlighted issues that have brought a lot of complexity to the case management care transitions role. As I said, care transitions is larger than just inpatient care management. It also encompasses the community and encompasses going from acute care, post-acute care to wellness.
A lot of chief nursing officers that are listening to this are going, yeah, my biggest problem right now is probably getting my patients out. What are some things that we can do to facilitate that?
Complexity is something that is in our world now. I think COVID has changed the world and highlighted health inequities. Our patients that perhaps 5 years ago were being discharged were going to a different settings, that being more stable home environment, not going to post-acute care or subacute care. There's a lot more refers to a lower level of care and not home. And we all know that the social determinants of health have really impacted that. We have economic instability. Access to quality care is an issue, and that addresses our issues with readmissions, making sure that patients are able to have the care that they need and the interaction or the appointment with their physician post-discharge. There's issues with food, with transportation. How are patients going to get to appointments? Are they going to choose to buy food or to buy their medications? And then neighborhood, housing, insecurity. We discharge more patients to shelters, to home, and have a lot more guardianship issues than we've ever had in the past. So I think that as nurse leaders look at how do they support, how do they build and become creative in being able to support care transitions and decrease that length of stay, we have to look at what kind of patients we have and how has our society changed. It's so important as our patients have become very vulnerable. Their populations are much more vulnerable than they were in the past.
You mentioned a word that I've seen with two recent clients that I've been working with as barriers to discharge, and that's guardianship issues. Can you talk a little bit more about that and the complexity of the problem?
Sure. Patients are vulnerable. The guardianship issue has become a real barrier to discharge, as well as a barrier to wellness and healthcare in post-acute. A lot of our patients that I have seen have healthcare proxies. They have unstable family units. So they perhaps need to have somebody making the decisions for them, and they don't have family there to do that. So that's when case management, primarily social workers, are then applying for guardianship because they're incapacitated. And that has to go through the court system. And we know that the court systems are bogged down with multiple issues, but probate court, Sometimes it takes even up to 2 weeks to be able to even get an appointment with a judge to go before the court to be able to apply for guardianship and to get it approved by a court-appointed guardian. And you can understand how that delays discharge. The patient is ready to go medically, but really needs guardianship to be able to care for them outside of the hospital systems. That is a real barrier to length of stay reduction.
Is there anything that can be done to mitigate the length of stay issues while guardianship issues are being worked out in the courts?
That's a tough one because I don't see that there are a lot of support systems within the hospital system and or the current hospital structure to be able to mitigate this. You can't let the patient leave if they're incapacitated. You can't, it's an unsafe discharge. I don't know that we'll be redefining safe discharges in the future, but unfortunately, that is a large driver of length of stay reduction. The other large driver is post-acute care. A lot of our patients now with, as I said, COVID and complex social environments as well as complex physiological issues are having to go to subacute care, to SNFs, to LTAC, to foster adult homes. There are issues with being able to get the patient placed. That's where insurance comes in. That's where it all ties back to those social determinants of care. The patients are uninsured. How do we then be able to have the patients placed in the appropriate level of care to be able to transition from the hospital? It is a dilemma that we are all going to have to look creatively at to be able to decrease that length of stay and or make sure that the patient has a safe discharge.
Okay, so we've talked a little bit about the barriers. One just is a bed available that's in the SNF or LTAC. The other being the guardianship issue. Despite those barriers, then, if I'm a nurse executive and I've got length of stay opportunities, what are some areas that I should focus on where I can leverage success? And are there areas of innovation that I should also maybe be thinking about?
I think that's a great question because I think that in the literature as well as standards and structures in professional organizations have really looked at this as an opportunity, if you will. Nurse executives need to look at this complexity as an opportunity to be able to be creative, to use interdisciplinary teams. I know we've talked and we talk a lot about that in multidisciplinary rounding, but I think that collaboration and changes in relationships are something that the nurse executive can formulate, can drive to be able to build associations in post-acute care and bring those into the inpatient setting. For example, we know that even in the ACMA, the American Case Management Association, their standard number 5 in the continuum of care says processes need to be in place to ensure timely transfer of essential information to key stakeholders. Those key stakeholders have changed. You have ambulatory providers, you've got subacute care now, you've got payers, the ACOs, and then you've got care managers and episodic, they're calling them, episodic care managers that are in the outside of the inpatient world. So the reason I mention this is because we need to change our relationships and and the teams are going to look different. Interdisciplinary teams have been structured in the inpatient setting. They're formulated. We know that we need to do multidisciplinary rounds as we go through and look at length of stay. We know that works. Bringing the group together, looking at the barriers to care, addressing those barriers while the patient is in the hospital way prior to discharge. So you're not waiting to the last 2 days before the patient is medically stable to go home. But the other piece of it is, as it builds on what I talked about with the social determinants and the complexity of the post-acute care, that nursing leadership or that chief nursing officer, nurse executive really needs to be creative in building the bridge from inpatient to outpatient through evidence-based practice. And evidence-based practice says interdisciplinary care teams or interdisciplinary teams are those teams that are going to drive the next change. The teams are going to look different. They're going to look much different than they are today. And so with that, I think that's an opportunity for the nurse leader to use the uncertainty, if you will, of the current environment and change the paradigm in care transitions. It's using that nursing professional practice, interdisciplinary teams, nurses practicing at the top of their license, which is something that we always look at, not only in care management and care transition, but in the nursing profession overall. So I think it's an opportunity for, and a challenge for nursing executives to be able to change this process, change the paradigm of work, of thought, to how care transitions can be successful in the new world.
What I hear you saying, let me make sure I understand it correctly, is many hospitals right now have multidisciplinary teams, but those teams are usually on that unit. On the unit, you've got the nurse, the physician, ideally the pharmacist, the case manager, maybe PT and OT. But what I hear you saying is that we really need to look at this multidisciplinary care team as across the axis of care or the continuum of care, and reaching out to involve those of where that patient may be going. There is increased collaboration, and not just maybe the case manager saying, okay, I've got the information, I'll check with this agency or that agency or things of that nature. Am I understanding that correctly?
Absolutely. I think that it's not about handoffs anymore. It's about communication, interdisciplinary communication, and not, as I said, a handoff. Our current environment is exactly as you said, Nick. It is discussing the patient's care, their continuum care, their progress towards discharge. We need to change that team a little bit if we can, and then have that communication further up the care chain, if you will, for the team to understand the complexity of the patient and be able to plan earlier. It might not happen all the time. We know that a lot of our patients go home without home care, but for those complex care patients, it's essential that we change the team, because those are the patients that are going to be the most difficult to place. We all have complex care teams in hospitals and complex care rounds where we look at patients that have a length of stay of over 5 days or over 10 days. We need to be shifting the team and the discussion and the membership of that team to those patients that we know are going to be complex discharges, which are increasing in nature. When we used to have complex care rounds years ago, there may be 5 to 10 patients on the list. Some hospitals have 20 patients on their list that have been in the hospital greater than 10 days and some up to 45 days. It is a different approach to care transitions. It's bringing the discussion closer to the inpatient setting than it is a handoff after. I hope that helps, answers your question.
Yeah, it does. What role should the family play in these rounds, these discussions? How does that get operationalized when you're trying to go through patients on a 40-bed unit in a multidisciplinary round perspective as quickly as possible, right, and not deal with privacy issues from one patient to the next?
Right.
How would you operationalize?
That's a great question. I look at interdisciplinary rounding and length of stay reduction, excess stay reduction initiatives in a 3-legged stool. In the current environment, a lot of hospitals do interdisciplinary or multidisciplinary rounding. What they do is they get together, they sometimes are on task and sometimes not. There's a lot of variation in the practice. Who facilitates the discussion? Does the nurse give a report? Does the doctor give a report? That is something that we work on with hospital systems and with individual units at the unit level as a primary function or a primary improvement. The second piece is for that team to get together in the afternoon to talk about discharges, very quick, talk about discharges, that being the nurse case manager and the charge nurse or the facilitator to help tee up discharges for the next day. But to answer your question, the third leg of that stool, which is almost more important than the others is the connection between the information that's talked about daily in interdisciplinary rounds be communicated to the family and the patient on a daily basis through a few different mechanisms. One is use that whiteboard that's in the room. Every hospital has patient whiteboards in the room that are used in a variety of ways. I would suggest, and I believe that this a fundamental approach to communication with patient and family is to not only put the nurse's name and the care manager's name on the whiteboard, but also show the patient, educate the patient. This is your estimated date of discharge. This is when we think you're going to be going home. Offering, and on that whiteboard, offering any questions that the patient and family may have. But most importantly, for that nurse and or care manager or both to be able to use that as the dialogue starter on a daily basis to not only tell the patient when they think they're going to go home based on their condition, but also to remind them as things change, because we know that we can put an estimated date of discharge of 5 days or 4 days for congestive heart failure, but things may change as the care continues. So to update them consistently and ask the patient if they have any questions. I think that we as nurses sometimes, and this is a whole nother topic, but we're very automated and we're very busy and staffing is an issue, but we come in and we do what we think we need to do from a task orientation standpoint, and we don't look at the patient as a whole. We need to look at their psychosocial condition as well. What do they need to be able to successfully transition out of the inpatient setting? So I think that those three components, but most importantly, to your point of patient and family, we need to communicate to the patient and family on a daily basis when we think they're going to be going home, what's next in store for the day, and how they can help to be able to have a safe discharge, which includes, for some family members, it includes taking the patient home as soon as the discharge is going to be written tomorrow, you're going home tomorrow. Talk to that patient today so the family doesn't say, well, I don't have a ride, those kind of things. That's for patients going home. For other patients, as we've talked about, is those complexities to start addressing the discharge at day one of admission. If the patient came from a nursing home, if you know that the patient will not go home initially, to start to talk about that with the patient and or the family. And on a totally different topic, we need to have nursing really focus on mobility. I think mobility is a huge issue as patients come into the hospital and go home. They've been here for 4 days, and perhaps they came in walking and they've been in bed for 3 days, and now they have a mobility issue. And that dictates where their next level of care is. So that's another nursing professional practice, nursing component that can really help move the patient to discharge. It's an interdisciplinary team. It's multifocal and it's multidisciplinary.
So let's talk about multidisciplinary rounds real quick and just ask some nuts and bolts questions in a rapid fire format. How long should multidisciplinary rounds last?
1 to 2 minutes per patient.
Okay. And how often should multidisciplinary rounds occur?
They should occur daily, and with that follow-up of the nurse, the charge nurse and or a case manager, a social worker in the afternoon to facilitate discharges for that day and the next day.
Who should be present at multidisciplinary rounds?
The interdisciplinary team consists of the primary care nurse, the physician, the pharmacist, social worker, care manager, physical therapist, nutritionist, dietitian, and the community resource person, the person that will help facilitate the discharge to home care. As I said, a lot of our patients go home without home care. Some patients go home with home care. That's another person we want at the team, the facilitator for home care, to be able to put the request in prior to discharge.
When's the best time to have multidisciplinary rounds?
That's something that is a variation of practice. Best practice is between 9 and 10 o'clock in the morning. That provides the team to be able to do the work that they need to do. Afternoon rounds are too late. And 8 o'clock in the morning, sometimes the hospitalists, the physicians, and the case managers need to prepare for the round. So between 9 and 10 in the morning is really optimal.
What's a good measure of success of knowing that your MDRs are successful?
A couple of things. One is the team values them. The nurses feel that they have communication enhancements with the team. Some outcome measures you can measure is less calls to doctors, especially decrease in excess stay and length of stay, and overall satisfaction, patient satisfaction. In the HCAP scores, there is a question in the HCAP scores where you communicated to. Did you feel your discharge was communicated? And those are the outcome measures that you can specifically tie and trend into success.
And I think a hotly debated topic usually when you're implementing MDRs is to script or not to script. That is the question. What are your thoughts around the use of scripting in MDRs?
Scripting helps facilitation of the focused discussion. I believe in scripting. I believe that we sit in MDRs. Sometimes they sit in a conference room and start talking, get off script, start talking about things that really aren't relevant to the discussion. Scripting is essential to be able to be focused and to be able to have it an efficient discussion on a daily basis.
Are there any other key pearls of wisdom you may have around how to make MDRs highly effective?
You need to have a visual management system, and you need to have that visual management system that's easy to use, that is available to the entire care team, that very quickly and concisely looks at barriers to discharge, how the patient's being transported home. Are they going home today, tomorrow, the next day, or more than 2 days? And can be updated by the care team, that being a physical therapist, that being a pharmacist. So it's a dynamic document, not something that's a computer document that sits on the computer and nobody looks at it till the next day. It should be out in front of the care team to be looked at consistently and updated consistently.
My last question is wrapped around maybe one thing that you know about care transitions and now that you wish you knew earlier in your career.
The wisdom that I can impart is nothing is easy. Everything in healthcare is complex. Nothing is easy, but there's always an ability to learn from your experiences and use these dilemmas, these complexities, as I've just talked about in the last couple of minutes, to creatively build something that meets the changing needs of nursing practice, care delivery, using best practice, and most importantly, bringing in the interdisciplinary team wherever it is and whatever it looks like, because it may look different in different settings.
Great. Any additional closing thoughts you might have, Joe?
The healthcare team is a driver of coordinated care by seeing the whole patient, not just a disease, but the person's struggle with psychosocial issues, and it's bundled in their disease process. We need to work to break down the barriers the patient faces, both financially, psychologically, and physiologically, to support those patients through the journey and to make the healthcare system arena a safe place for discharge using an interdisciplinary team. I think it's most important.
Great. Thank you so much. I appreciate your time today, Joe.
Thank you so much.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.